Hi, everybody. I'm Vicki Keedy. I see some faces. So happy to have you here. This is a wonderful turnout. We're so happy to have this in Nashville. And am I speaking loud enough? Okay. All right. So basically, I'm talking about systemic therapies. So treatments that you get through your mouth or your IV or something like that to go and treat the TGCT. I think you'll have the surgical session later, I believe. Okay, perfect. All right, I know that maybe. Nope. Nope. I'm not advancing. Got a little dirty good sometimes. Now try it. Okay. So I may be repeating a few things as I go through this, but I think the biology of TGCT is incredibly important to understand as to why we have the treatments that we have now. And you all know this. This is the standard patient journey. You go around in a circle between your PCP and a rheumatologist and sports medicine, and eventually you get this diagnosis of TGCT. Hopefully it's from somebody who knows how to treat TGCT and can have that multidisciplinary discussion about whether surgery is the right next step, whether therapy is the right next step, whether observation is the right next step. And often patients get to us in medical oncology when they get to an orthopedic oncologist who says, well, now we're looking at a front, back, or a joint replacement. You're too young for that. Go see my medical oncologist. Okay. So to kind of, again, I think you've seen this biology already, but I just want to go through it. For reasons we do not understand, these synovial cells get this type of mutation called a translocation. Translocations happen in a lot of cancers, and particularly a lot of sarcomas. And we don't know why they happen. We don't know what the inciting event is for this to happen. But this particular translocation puts CSF1, which is colony stimulating factor 1, next to this transcription factor called COL6A3. And they shouldn't be together. And because they're now together, that CSF1 gene gets interpreted into the CSF1 protein, which is called a ligand. That ligand goes into the system and goes to our immune cells. And one of the specific types that it targets is called macrophages. Tumor-associated macrophages are common in lots of cancers. It's one of the reasons why immunotherapy may work and some other types of therapies. But these macrophages have a receptor. It's a tyrosine kinase receptor called CSF1R. That ligand binds to that receptor, and the macrophage says, I'm going to wake up, I'm going to activate, and I'm going to go find that cell that just signaled me. Okay. So it recruits these macrophages to the joint, to the synovial cells. And the other thing that happens is there is an autocrine loop. Basically, that synovial cell is also activating itself. So it also has CSF1 receptors on it. The CSF1 ligand binds to it, and the fibroblast or the synovial cell expands, and now you have this synovial mass in your joint. So blocking that process, once we learned that this was what was happening and driving TGCT, we said, well, let's see if we can block this process. And luckily in cancer, like I said, we've already seen similar biology, and drugs were being developed to impact cancer patients. And then we kind of piggybacked on that for TGCT. So how do we treat TGCT when surgery is not the best option? And we have two main classes of drugs: tyrosine kinase inhibitors and receptor antibodies. So this is the cell membrane. This is the cell membrane, and you have this receptor. And again, it's the specific type of receptor is called a tyrosine kinase receptor. And in the normal cell, this receptor is turned on and off to tell cells when to grow and when not to grow. But in cancers and in TGCT, that signal pathway is messed up. So we have the antibody, which can be designed specifically for this receptor. So monoclonal antibodies are typically very specific to your target, and it essentially blocks that ligand from being able to bind to this receptor. And if that ligand never binds to the receptor, then there can be no signaling going on. Small molecule inhibitors, which are what we currently have that are FDA approved, actually get into the cell itself and prevent what's called phosphorylation of that receptor, which prevents the signaling. Okay. And we have many examples of this. And there are many different tyrosine kinase receptors. And this is one of my favorite figures I like to show my medical students because I don't think they truly understand what these families of receptors are. Again, these are all different types of growth factor receptors that are on our normal cells. It's a nice symphony of when they're turned on and when they're turned off. And this is how they're all related to each other. So this is like a family tree of receptors. And this group are the tyrosine kinase receptors. And there's a little purple dot right here, which is CSF1R. So when we are designing tyrosine kinase inhibitors, some of them are very broad and they hit all kinds of them. So for some of our drugs, you can see 20 different red dots there. This is actually Vimseltinib. So it's relatively specific to CSF1 and it's pretty potent. So the bigger the dot, the more active it is at that receptor. But you can see that there's other little tyrosine kinase receptors that it also blocks. And that leads to what we call off-target side effects. Okay, so it's unintentional. It's not what we're using the drug for, but those receptors are important in other body functions. And so we get side effects from that. So we have 4 tyrosine kinase inhibitors, either approved or in clinical trials. And so we're going to go through those. But before I do that, I want to talk about response. Because when you're reading a paper, an abstract, or a news story, or your doctor's talking to you, we typically use the word response. But it's not what everybody thinks it means. Okay, so if I was told response, I would say, well, my tumor shrunk. But it's more than that. For it to be called a response on a clinical trial, the tumor has to shrink by more than 30%. So you can have 29% shrinkage of your TGCT and be called stable disease. So what this looks like, this is called a waterfall plot. Each line is an individual patient. This is not TGCT, this is just an example. And the height or the depth of that line is how much that tumor has shrunk. We use what's called RECIST criteria. This is an international language. It's what we use in all of our clinical trials for most of our solid tumors. And what we do is we pick the lesions that we're going to follow at the beginning, and we measure them in the longest diameter. And we just measure that the same all the way through the trial, and we say the percent difference in change. So again, to be called a partial response, it has to shrink by more than 30%. So there was concern that RECIST would not be valid for TGCT. So this is an example of a knee. This is a knee from the side. All these white squiggly things are the tumor. So those are the synovial proliferation or synovial tumors. There's no straight line here, right? So when we do these trials, we're concerned, is this actually going to be valid? So when the Pexidartinib study was being developed, they also came up with what's called a tumor volume score. So rather than just longest dimension, they said, well, let's look at the volume itself. And this was from a regulatory standpoint, because what they were afraid of is even if we saw clinical benefit, if it didn't meet the RECIST criteria, the concern was the FDA would not approve it. So they wanted to have a backup just in case. Okay. I thought I skipped a slide. Like, where's my Imatinib slide? So we'll go into Imatinib. So Imatinib was really the original tyrosine kinase inhibitor in cancer treatment, initially developed for a leukemia called chronic myelogenous leukemia. And once we realized how important these tyrosine kinase receptors are for cancer growth, Imatinib was tested in everything, essentially, particularly in sarcomas where we didn't have a lot of effective therapies. So when it was identified that CSF1 was so important in this disease, people started getting off-label Imatinib. So 15, 20 years ago, I would only see a handful of patients with TGCT a year. And it was when they've had 3 different surgeries, they'd already had their joint replaced and all those types of things. And we would talk about whether to do off-label Imatinib. So when a drug is FDA approved for a different cancer, it opens up the possibility of giving it to a group of patients with a different type of disease. Okay. This was not a clinical trial. There's no randomized clinical trial data for Imatinib. But what we did is we said, okay, well, let's go back and look at the 30 patients we gave this drug to and what happened to them. So about 29% had a response. the study just kind of went back and said, how long were patients on treatment? Why did they stop? Most patients stopped just because they wanted to. Their knee was feeling better and they said, let me come off the drug. On average, patients were on it for about 7 months, and over 2/3 of patients had improvements in their symptoms. And this is called a swim lane. Again, each line is an individual patient. The blue is how long the patient was on imatinib. The red is how long they were off imatinib, and it kind of explains their story. It's basically proof of concept that this class of drug works for TGCT. I already did that one. So now we can go on to Pexidartinib. So I was actually the Vanderbilt principal investigator on the phase 1 clinical trial with Pexidartinib, so I have a lot of experience. That study started at Vanderbilt in 2009. What that study did is once they found the dose on that phase 1 clinical trial, they expanded it into different disease types. And TGCT was one of the disease types because they said, CSF1, they're basically looking for anything that CSF1 was important for, and TGCT, which we called PBNS back then, was one of them. And we saw great responses. Patients were coming to my clinic crying because they could hike again. It was fantastic. So from there, they designed the randomized phase 3 trial. And all of these trial designs I'm going to show you are very similar. So these were adults. You had to have biopsy-confirmed TGCT. That's the other thing. I get sent patients with MRIs that are concerning for TGCT, and I say, well, I need that actual diagnosis first, so get me some tissue for diagnosis. They had to have advanced disease, and on this trial, it was very specific. So I either had to have a surgical note or a tumor board note that said we did not recommend surgery, that we thought surgery was too morbid, or that it had a low chance of eliminating the TGCT. So it was very specific. Patients had to meet certain pain and stiffness scores. And again, this was 2012 or 11. Back then, it was almost a version of a BlackBerry. Patients took home. They had to log their pain score and their stiffness score every day. They had to do that for 2 weeks before they got on the study to prove that they actually had enough pain and stiffness to qualify. So it was very specific. I had to be able to measure the tumor. And ultimately, about half of patients had had no prior surgery. Once the surgeons heard about this, they're like, sending you everybody. Okay, and I had to turn away people. I'm like, you don't actually have pain. You're not eligible for the study. But about 10% of patients had 3 or more prior surgeries. So again, all these study designs are very similar. About 120 patients, 121 patients were randomized. Randomized means a computer decides what treatment you're getting. This is a double-blinded study, which means neither the patient nor the investigator knows what drug the patient is getting. And it was planned to be a 6-month study, where at 6 months, patients were unblinded. And if you were not getting Pexidartinib, you're allowed to roll over to Pexidartinib. Now, there's an interesting history with this because the liver toxicity that I'll talk about was identified. The Data Safety Monitoring Committee went, oh my God, we have to unblind everybody. And so this time point, not everybody got to that specific time point on this study because they unblinded everybody. And from there, it was an option of whether to go on, and we had to reconsent patients given because of the liver toxicity. But ultimately, 30 patients who were on the placebo went on to get the study drug. So the final data showed that the RECIST response rate was 39%. So it actually is a valid measurement for this disease, and it met its endpoint. But also showed the tumor volume score probably speaks a little bit better to what we're seeing. So again, we have these waterfall plots on the right. The top line are the RECIST criteria responses. And as you can see, every patient except for one had some degree of shrinkage on Pexidartinib. And the data were same for the tumor volume score. But again, a larger portion of patients met a response. Interestingly, on the placebo, a few patients had some shrinkage. We know this tumor can wax and wane, but also is it just because it's difficult to measure? And maybe from one MRI to another, if your knees pivoted just a little bit, that can change my measurement quite a bit. What they also showed is that patients who showed This number down here is higher. Patients who are on drug longer continue to get shrinkage. Okay. So then let's talk about side effects. So what we recognized was hair color change was very predominant, and it's actually probably 100%. That just may not have been reported at all the sites, which also made it very difficult to blind, right? Because if the patient walked in the room and I'm like, your hair is not white yet, we pretty much knew. And the FDA was worried about that. So what they made us do was blind our physical therapists who were doing the range of motion studies. So they weren't allowed to know what the drug did. They had to sign a thing that said they weren't going to look up like the mechanism of action of that drug. So they at least felt like the range of motion assessments would be blinded. I was part of the advisory board for the study, and they were talking about having patients come in with like towels on their heads and all that, but then they realized their skin color lightening too. So they backed off on that. So that was a big deal. We did see a little bit of rash. We did see a little bit of edema, a little bit of GI effects, but to point out why randomized placebo-controlled trials are so important for these types of drugs, I can't see that far. But if you look at the GI stuff, the percentage of nausea and diarrhea was almost identical in the placebo group. It just shows how much GI distress we all have. So that's why it's important to do placebo-controlled trials with this type of disease and these types of drugs, because it would have made it look like this has terrible nausea, but 40% of the placebo group also had nausea. Okay, and then what did come out is this hepatotoxicity. So it's elevations in what we call the transaminases, or the AST or ALT. But it was a specific type of liver toxicity. And in a completely separate study, I believe it was melanoma, they actually had a patient go into liver failure. And so that's why the Data Safety Monitoring Committee kind of unblinded everybody. Now, as an oncologist that uses these drugs every day, we already knew that. We weren't surprised. This is a tyrosine kinase inhibitor. If you treat enough patients with tyrosine kinase inhibitors, you're going to see liver toxicity. So we're just used to this class of drug. But because TGCT is not a cancer, we take these types of side effects a lot more seriously. So the FDA was impressed by the data, the results, and the patient-reported outcomes, and approved the drug in 2019, but they approved it on what's called a Risk Evaluation and Mitigation Strategy Program, or a REMS program. So there's a couple of other drugs like thalidomide, if anybody's heard of that, that is on a program like this. And what this entails is that the physician must be registered to provide. And I had to do a little training module, even though we had both of these studies. The patient has to register into the program and sign consents. And it's pretty intensive lab monitoring, particularly for the first couple months. So you get weekly liver tests for the first 2 months. For most of my other tyrosine kinase inhibitors, we'll do it about every 2 to 3 weeks for the first couple months and then spread out, and then every 3 months as long as you're on this drug. It can only go through one specialty pharmacy, so that they can track that and dispensing. There was a fear that the sports medicine doctors or the orthopedic oncologists would suddenly start giving these medications to people. It should have been, none of them went anywhere near it, but they just wanted to make sure that the person prescribing these medications were qualified. And this definitely causes problems for patients who don't live near a center that has a TGCT specialist who has access to this drug. I always say the only good thing that came out of COVID is telemedicine. So it makes monitoring much easier. However, I only have a medical license in Tennessee. So I can't see patients by telehealth unless they're in the state of Tennessee. So my patients down in Alabama, where there really aren't many prescribers or any prescribers, it can be much more complicated. So luckily, on the heels of this came from Vimseltinib, another tyrosine kinase inhibitor. So same mechanism of action, again, hits slightly different tyrosine kinases at slightly different potencies, very similar patient population. They had to have moderate pain or stiffness scores, which I believe was 4 and above. And they specified that there had to be a tumor that was at least 2 centimeters for me to monitor. So about 26% of patients had had no prior surgery, and 12% of patients had 4 or more surgeries. So again, pretty heavily treated patient population and exact same design. The only difference was the randomization was 2 to 1, meaning 2 times the number of patients got the study drug compared to the placebo. It's a very valid statistical design. It lets more patients get the drug up front and also is more patient friendly, and patients are more likely to volunteer for a randomized study if they have twice the chance of getting the drug. Again, they had a set time point where everybody was unblinded. We found out what they were on, and they were allowed to go cross over to Vimseltinib if they were on placebo. So here's the results, very similar to Pexidartinib. Resist response was about 40% and tumor volume score was 68%. They also reported significant improvements in range of motion, pain, physical function, and stiffness. Unlike Pexidartinib, and I'll show a study later, right now we don't know much about the duration of response. We will be getting those data, but it's just a newer study. So toxicity is slightly different, okay? So this was not approved on a REMS program because they did not see this more severe liver toxicity or this cholestatic liver toxicity. But just be aware, they did still see increases in AST and ALT, so we still have to monitor. Again, it's a class effect. We know this is what these drugs do. But because they didn't see any severe toxicity, it is FDA approved without the REMS program. Okay. However, there's more rash and there's definitely more edema. I would say the biggest issue with my patients has really been the edema with this drug. 53% of patients did require dose interruptions, and 42% of patients required dose reduction. And we learned this with Pexidartinib. So Pexidartinib, the original recommended phase 2 dose was significantly higher than what we give now. We learned we don't need to treat at the maximum toxicity doses, which is what we typically do for cancer. We can often get away with much lower doses and get responses. So we're pretty apt to decrease the dose for patient tolerance. Okay. So those are our currently FDA-approved drugs. So moving on to other systemic treatments that have now completed trial, but have not gone to the FDA. We have Imatinib, called the maneuver. The trial names just get more fancy. Same population, okay? However, slightly higher percentage of patients again had no prior surgery. And the exact same design, and I forgot to point out, let me go back, that the Vimseltinib is twice weekly dosing, okay? Where Imatinib is daily dosing, and Pexidartinib is twice a day dosing. And this all just has to do with what's called the pharmacokinetics. How does the body break down this drug and how long does it stay in your system? So that's why there's differences in the dosing schedule. Same results. Response rate was 54%. The tumor volume score was 62%. Again, the patient reported outcome data was very impressive, improvement in pain, improvement in stiffness, improvement of just overall quality of life, because then that's another important thing. If I'm shrinking your TGCT and making your knee better, but you otherwise feel terrible, then are we actually helping you, right? So the FDA feels these patient-reported outcomes are very important. Again, study just completed not that long ago, but again, impressive waterfall plots on the left there. So toxicity, I would say, is actually very similar to Vimseltinib. So again, 54% of patients had to interrupt their dose. Only 8% of patients had a dose reduction, so just kind of interruptions were enough for patients, and very few stopped for adverse events. This stands for treatment emergent adverse events. All clinical trials speak. So again, rash. So 52% of patients had itching, and that itching can be very annoying. 34% had rash, and a few of these patients got to a higher grade. So when you come in on a clinical trial, we assess every single abnormality. how tired you are, every lab abnormality, and it has a grade, and we have to grade it. And so there were patients that had grade 3, 4 itching and rash, so rash is like over a certain percent of your body, and itching is impacting your daily living, essentially. Some GI effect, but also still edema. So 47% of patients had edema. No one reported high levels of edema. And again, about 30 to 40% of patients had elevations in their liver enzymes. So still a class effect and still has to be monitored. But they did not see any drug-induced liver injury, which would be a higher level of liver toxicity. So switching to monoclonal antibodies, that's a Google AI image. Isn't that pretty? I tried it for other things and it didn't work, but I thought this was really pretty. So basically, this is the cell membrane. Okay, this is your receptor, and here's your little antibody. Much more complex than our little Y picture that we show on most of our slides. So Imatinib, or the Tangent trial. So this is a monoclonal antibody, and this is given IV. Antibodies are IV infusions. This drug had been kind of in and out of trials for a while, but finally a company said, okay, let's do the right trial. Because the most attractive thing about this drug is that it's a limited amount of doses. So you got every 2 weeks for 5 total doses. Okay, again, randomized placebo-controlled trial. The other interesting thing is they included the adolescent population. And so there was a separate sub-study for patients between 12 and 17 years old. I've not seen those results yet. So this is what we have so far is basically a press release. So this just came out 3 months ago now. And a press release is when they look at their data and their statisticians say, you met your endpoint. So whatever you wrote in your protocol that was going to be a successful study, you met it. And then they send out this press release, and that's primarily for their investors, so you know. But it doesn't tell you the degree of benefit. It just says we met our endpoint. So we need to see the results on this. They do report their toxicities. And again, it's very similar. So it shows that the itching, the rash, and the swelling is specific to CSF1R. Okay. Because monoclonal antibodies are very specific to that receptor. So that is what we call an on-target effect. We're hitting the target we want to target, but it still has side effects. Okay. So we'll wait to see where this drug goes as well. And then last, and I think this is going to be unfortunately, the death of AMB05X. So this was an intra-joint injection of a monoclonal antibody. And unfortunately, it closed early with only 11 patients on study. We actually did not open this study. Just doing interventional radiology trials can be very complicated. And so that may have also been part of the problem. Is that interaction it can sometimes be difficult to systematize. So unfortunately closed. They do have to report the results, and they actually already did, believe it or not, in a portal called ct.gov. All of our clinical trial data is supposed to be reported there, and I believe it was something like a 20% response rate, but it was only 11 patients. So I'll next go to not all patients need systemic treatment. So how do we decide? It is complicated, and this is why being at a center that has a multidisciplinary group of physicians, radiologists, surgeons, and medical oncologists that understand this disease and the options available to you can be very important. So the questions are, how bad are my symptoms from my TGCT? Or is it impacting my life? What's going on in my life? Do I have time to get weekly labs or every 2-week labs? Am I wanting to get pregnant soon? Because you can't be on these drugs during pregnancy. Let's talk about, what is your goal? Do you want improved pain? Do you want to be able to hike again? What are we actually aiming for if we're going to do this treatment? And then overall, just that balance, risk and benefit, okay? And that leads to impact on quality of life. So it's not about the response rate. Every slide I said, response rate, that's what got the drug FDA approved. But really what we're most interested in is improvements in your overall quality of life. So all of these studies had very rigorous patient-reported outcomes. We had to have, like I said, physical therapists that did very formal range of motion training. We have to track your pain scores. We had to track how much pain medication you were taking, all those types of things. And then the patients on studies filled out these very lengthy forms. And all of the studies are very similar. Basically, patient-reported outcomes were better for pain, stiffness, overall quality of life, and motion. So we have to find the right patient who actually is going to benefit from this treatment, who have to accept the possible side effects. Now, how do we choose which agents? So we can start with Imatinib. I don't start with Imatinib. It's not FDA approved. But it's really cheap. So if we're having trouble with insurance coverage or you have terrible specialty medication coverage, I can usually get somebody Imatinib for about $47 a month through Cost Plus. Okay. That's the Mark Cuban pharmacy, if you don't know what that is. However, we don't have robust data. The quality of data is low for this. I don't have a randomized study. We don't have any patient-reported outcomes. Is quality of life better on this drug? And the response rate reported is lower than with the other drugs. It hits CSF1R, but not very potently. It hits a lot of other things much stronger. Okay. So then we have Pexidartinib, and unfortunately, the REMS program is what is causing Pexidartinib a problem, because as somebody, a clinic who has to do the REMS program, my nurse wants nothing to do with it if we don't have to. It's a lot of work on staff. And then again, patients have to get weekly labs for 2 months. So the pros of it is that it's what we have the most long-term data for. We have a lot of experience with it, and we do know that there are long responses off of treatment, and I'll show that slide in a little bit. But the cons, like I mentioned, the REMS, the liver toxicity, the twice-a-day dosing, the fact that you have to do a special low-fat meal, that's better than fasting, which is what the original label said, but still a little annoying. So then came Vimseltinib, and most of us have switched to using Vimseltinib first because of those reasons. The twice-a-week dosing is nice. You don't have the hair color changes. We haven't seen the severe toxicity. However, I do feel that there is more edema. There is more itching and probably more GI side effects. And again, right now, we don't have any long-term data as to what happens when you come off drug. Okay. So the drug's been approved for a year and a half now. So I've got some patients that are starting to come off of it, and we're going to see what happens. Okay. So Pemicotinib and Emactuzumab, the main problem with them is we don't know if they're going to be FDA approved. I mean, this is a rare disease. We have 2 drugs FDA approved that are quite effective, that are very similar. The Pemicotinib data looks very similar to Vimseltinib. We just have to see how the FDA takes it. Maybe the patient-reported outcomes are better. Maybe the rates of toxicities are better. You never know what the FDA is going to use to make this decision. And then similar to Emactuzumab, it's a little bit further behind Pemicotinib as far as its FDA submission. But it's possible that gets approved just based on ease of use. Okay. So we'll just have to see. So then back to the question of how long do you need to take it? So this was a phase 4 study for Pexidartinib. So that means it's already been FDA approved, but the company continues to collect data. And it was still small, only about, I think it was 30 patients consented to have their data continue to be collected. And what it showed is while you're on Pexidartinib, nobody had their tumor grow. So while you're on it, it works really well. But about over time, so this is follow-up of about 2 years, about half of patients did have progression of their TGCT and went back on Pexidartinib, but flip that. That means in 2 years, half of patients didn't have to go back on Pexidartinib. And oh, that's right. Yes. Thank you. Man, Sydney, keeping, yes. Thank you. So it was radiographic progression. Sorry, thank you. So half had radiographic progression, but of those, and again, this is a relatively small number, only 3 restarted their Pexi. So, and we'll talk about that. Thank you. I appreciate that. She probably knows this data much better than I do. So, all I can say is the data are more robust for Pexi. What are we going to see with these other drugs? It's probably going to be similar, I suspect. Some patients may be able to stop their drug and never have to restart. And patients who need to restart may get more than 2 years off a drug. Okay. And all of the patients that I had on the clinical trials have come off their Pexi for various reasons, and only one so far has come back with progression, and it was very small, and we just did surgery, and she hasn't had to have drug. So the answer is you let your TGCT symptoms and your drug side effects guide how long you're on your treatment. Okay. And I want to have someone in the room who we just kind of see how it goes. Pain increases, we start drug. Pain decreases, we stop drug. So it's not an all or none situation. So just talk about the risks and benefits with your doctors. So it's critical to consider multiple things. What are your degree of symptoms and impact on quality of life from your TGCT? Is it progressing on imaging? That's not really the most important thing. It's really, are your symptoms progressing? What we don't know, but we may suspect, is if we treat TGCT earlier with these drugs, then maybe we prevent some of the long-term arthritis and other joint changes that can kick in. And the one thing I forgot to say about the range, the symptom improvement is I warn my patients that even if I got rid of every last synovial site in there, you may still have pain and stiffness because many of you have had multiple surgeries, and that can lead to joint problems long term. And many people can have a lot of arthritis and erosions by the time they present to us. And treating the TGCT doesn't treat the actual arthritis that has set in. So just kind of set expectations too, is that you may not go back to normal. We just don't know yet. Kind of talk through the nuances of side effects. Do we need to think about fertility, timing? Right now, we don't have any data that it impacts long-term fertility, but all these drugs are always tested in animals, and all these drugs have impact on ovarian function in the animals, but we've not seen it in humans yet, but just part of the conversation. I've had plenty of women get pregnant after these drugs, by the way. So far, clinically, we've not seen an impact on long-term fertility, but you can't get pregnant on it. Social support, ability to comply with the toxicity monitoring. Can you get to the clinic? And then, are you interested in clinical trials? However, all of our clinical trials have currently closed, so we don't have anything great right now, but we'll see what's coming in the future. And I just have to give a big shout out to my team. You'll see them various parts of this meeting. This is essentially my TGCT team. Okay. So we've got adult medical oncology, pediatric medical oncology, my wonderful orthopedic oncology service, and our sports medicine. This is what's great about institutions like ours is our sports medicine doctors and our orthopedic oncologists talk back and forth, and they actually often share the TGCT patients. But there's a lot of support that it goes on with this as well. Physical medicine and rehabilitation. Those are physical therapy doctors who think about our patients differently than let's just strengthen your quadriceps types of things. Julie Bolger is basically one of our communication groups who helps get the information about these types of meetings and things out there and has the resource room and that. But we've got OncoPsych, we have OncoPain. They're going to be in the roundtables tomorrow, I believe. You've met one of my pathologists, our nursing staff, and I apologize to my orthopedists. I don't have pictures of their nurses and nurse practitioners, young adult navigators, lay navigators, and then luckily we don't need these guys in the corner anymore. So we don't really there's no need to do radiation. I would say probably the only time we would do it is if I had an older patient that wasn't tolerating drug. The side effects of radiation take years to show up. So if I've got like a 70 or 80-year-old that I don't expect to be alive for 40 years to get radiation toxicity, we could say, okay, well, maybe we can slow down this TGCT if you're not tolerant. I would still try drug first. Okay? But for most patients, we don't need them anymore. But they're great if you do. And I think that's it. Yes, we have a replica of the Parthenon. Go see it. And that's inside. So anyway, that's what I have.